Good evening. Thank you so much. So I hope you are all well versed with the BLS which was taken last time. There will be some overlap, but then I'll try to concentrate more on ALS, the drugs as well as post cardiac arrest care. As you know, our advanced life support will only be effective if the basic life support is given in the most appropriate manner. Hope I'm audible.
കേൾക്കാം സർ കേൾക്കാം.
So can you unmute and tell me the goal of CPCR basically? What is the aim? What are we trying to achieve by giving the compressions? So what you have to understand is that it's going to start something that has stopped. What is that something is the pumping action of the heart. Okay. So our goal of CPCR would be to pump blood, which the heart was doing perfectly. Okay. So the next question comes, is only blood needed? You of course need oxygen also. You are not supposed to pump blood that does not contain oxygen. And where does this blood with oxygen go to? So that will go to all parts of the body, and the organs that would be most affected or helped out would be the heart. Okay. So that the waste products that are accumulated in the heart because of the lack of blood supply would be washed off, and the heart would get further oxygen and nutrients, so that heart would start to pump again. Okay, that is the reason why blood flow to the heart is important. Second, the lungs. What is the importance of giving blood flow to the lungs? That is to pick up more oxygen. So if you are not ventilating the patient, the blood that is passing through the lungs would not get oxygenated. So ventilation is also an important part of the CPCR. And last but not least, to the brain. So why is that important? That is important because that's to prevent you getting a brain dead patient at the end of registration. Even if you do your CPCR very perfectly, there would be changes that occur in the neurons as early as 30 seconds. That is microscopic changes. And by around 1.5 to 2 minutes or in up to 3 minutes, you would get hypoxic ischemic encephalopathy, from which the patient will find it very difficult to recover from. So they would be in comatose, vegetative state, minimally responsive state, and you might have to do a tracheostomy to wean them off, and they will be bed bound. So this is the importance of doing the CPCR at the right time with the highest quality. And this is the step. So in 2025, we had a recent guideline that came in October, and this guideline has changed this is called as a chain of survival. This basically is the steps that we do during CPCR. CPR or CPCR. CPCR is cerebral also, cerebral cardiopulmonary cerebral registration. So most of the time we use CPR, cardiopulmonary registration, but the brain is also one thing that would need registration. So in the chain of survival, I told you the steps. Then why is it shown as a chain? That is to show that all the steps are equally important. Okay, so if one step is weak, the link is weak and the chain becomes weak. It will lose its strength. So the outcome would be not very good. All steps are equally important. That is why it's shown as a chain of survival. And last time we had 2 chains of survival depicting. So you have types of cardiac arrest is one that occurs inside the hospital, that is called as a in-hospital IHCA, and out of hospital, where the patient is either at home or some shop or something. So we had 2 chains of survival, and that is now removed, and we have only 1 chain of survival. That is one of the changes that came in 2025 guideline. That is to simplify, and we assume that all the preventive steps, first step was to prevent a cardiac arrest. So we assume that all the preventive steps are taken properly. So that link is given away, and we have the steps. And one of the first step that you do is to identify that the patient is cardiac arrest. Sometimes we find it difficult to decide when to start CPCR. When to start CPCR is a very important. That tells you that you have recognized cardiac arrest. Okay, and once you recognize, you have to activate the emergency medical service. I think hope these things have been discussed in BLS. Okay, you have to activate. I will not be discussing about pediatric registration, neonatal registration. Most of my slides are for adults only. So in adult scenario, you have to activate. Even if you are in adequate number, you have to activate. Okay. And then it is high quality CPR. Hope you know how to say the quality of CPR is good. It might have been discussed in the previous class. Third step is defibrillation. Defibrillation can occur in BLS as well as ALS, advanced life support, adult advanced life support. Okay. So defibrillation can be done with AED, which comes as a part of your BLS. Whereas if it is done in the hospital setting by doctors or people who are trained in that, becomes defibrillation with the biphasic defibrillator. And hopefully we hope that the patient has something what is called as a ROSC. ROSC is return of spontaneous circulation. And then we have the effective advanced registration, which goes on to the integrated post-cardiac arrest care. Okay, and then recovery and survivorship. So these are the steps of CPCR or CPR. And we will be discussing about the defibrillation, because we have to be talking about biphasic, which is available, not the AED, which is available in the hospital, manual biphasic defibrillator, as well as advanced registration, as well as post-cardiac arrest care. Okay. So we'll try to make it as simple as possible. I would like to highlight the names of the rescuers. Who will be a rescuer? So as you know, we have a lay rescuer who is not a healthcare provider. He has nothing to do with healthcare. But that rescuer can be trained or untrained. Okay. So trained means like policemen taking part in CPCR training, ticket vendors, NCC cadets, all people who are likely to come in contact with people with cardiac arrest can be trained. Then you might be imagining, how can an untrained lay rescuer give? So when this lay rescuer calls the 108 or 911, whatever the emergency number is there, that person would train the lay rescuer to give compressions. There may be not ventilation. That is called as compression only CPCR or hands only CPCR. Okay, CPR. We are all considered to be healthcare providers, and there is no role for an untrained healthcare providers. All the staff working in the hospital should be trained in CPR. And in the 2025 guideline, they have specifically emphasized the need for a ACLS trained person in the code blue team. Okay, you have a code blue team every day, and in that team, in the in-hospital cardiac arrest, that one person should be ACLS trained person. And another recommendation that has been given in the 2025 guideline is that the team who does the out-of-hospital cardiac arrest can decide on termination of registration at the scene. That is, don't bring patients who cannot be reinstated into the hospital. I am not very sure how practical that would be. This is the AHA guideline, that is Western guideline. So in those areas where the team going to revive or restate the patient, if they find that the patient cannot be restated, they can decide. There are definite rules and guidelines that are given. They can decide to terminate and not to declare death at the scene, and not to bring the patient to the hospital. And in out-of-hospital cardiac arrest, every step should be done to prioritize registration. So this team almost should have everything with them, including the AED, to achieve sustained ROSC. So if the ROSC is return of spontaneous circulation is not sustained, again, you have to think again whether to bring the patient to the hospital or not. Again, practically may be difficult to follow in our setup. Next question is the patient to be taken to the hospital immediately when you find the CPCR, cardiac arrest? The answer is no. You have to give CPCR at the location. Okay. At this scenario, if effective CPR is feasible till our ROSC is attained. So most of the time, our patients, our restaters or rescuer would give CPCR, but then meanwhile, they will also transport. They will not wait for the ROSC to occur. And by activating the emergency system, you would be having the defibrillator, especially the AED, and people who are trained in ACLS coming to the location where the cardiac arrest has occurred. So the general rule is that you have to start CPCR and try to achieve ROSC before transporting the patient to the hospital. But in our setup, it might not be possible. You have to, but remember, you have to continue your CPCR during the transportation. And most of the patients that come here who have had lay rescuer or bystander CPCR, even nurses or doctors did the CPCR, most of them have hypoxic ischemic encephalopathy. So effectiveness of CPCR should be like we should check whether the quality of CPCR is quite good. Okay. Algorithm, there is no much change in the algorithm regarding the basic things, but what you do when you find a patient who is diagnosed to have cardiac arrest is to start CPCR. Okay, start the compressions. Compressions are CAB. You give ventilation, and you have already activated the emergency medicine medical service EMS. So you will be getting the AED or the monitor. So attach the monitor, check the rhythm check. Once you do the rhythm check, you can classify patients into two: those who have a shockal rhythm and those who don't have a shockal rhythm. That is the basic classification. And that decides how do you manage further. Okay. As you know, a patient who is having a shockable rhythm, you should give priority for the shock. Okay. Meanwhile, continue CPCR. Don't stop CPCR till the defibrillator comes. You have identified, you have a patient who is monitored and it's not a defibrillator, but you have a monitor, ECG monitor, you have found it's VF. Okay. And the patient is in cardiac arrest. Don't wait till the defibrillator comes. You have to have good, high quality CPCR going on. We talked about ROSC, that is return of spontaneous circulation. How do you identify the patient has ROSC? So during the CPCR, we after 2 minutes or 5 cycles, we stop for a pulse check or the rhythm check. Okay. So during the rhythm check, we can palpate for the pulse, and the pulse you palpate for adults is the carotid pulse. Okay. So the pulse would be there. And if you are doing a manual blood pressure monitor, that will also be recording a blood pressure. But then other things that would show that the patient has return of spontaneous circulation is the end-tidal carbon dioxide. So I don't know, like if you are aware about the monitor called end-tidal carbon dioxide. That's very useful one, especially when you're like intubating, you can confirm the position of the tube. And if there is return of spontaneous circulation, the heart starts to pump effectively. Okay. There will be blood going to the lungs with carbon dioxide, and that carbon dioxide will diffuse across the alveoli, and then it will come out in the exhaled gases. So that is called as an end-tidal carbon dioxide. It should be more than 40. And that usually occurs when the patient has a spontaneous circulation. And if you're lucky to have especially an ICU patient, you already have an arterial line. So you see the pulse waveform, pressure waveform. That is spontaneous. Even when you stop your compressions, you can see the waveform coming. That is another indication of ROSC. And different chapters have this, what do you call, the tables being shown. Basically, you can, any of the guideline or recommendation that they make is classified according to the strength of like support that you have to do or whether you have to do. So if you have a class 1 recommendation, class of recommendation, that's called a COR, class of recommendation. 1 means it should be done. So you have a lot of benefit doing that. Risk is very less. When you come to 3, it is harm, so it should not be done. So if I say it's class 1 recommendation, it should be done. Class 3 should not be done. And then class 2 is divided into 2A and 2B. And then we have class 3, which is again divided into no benefit as well as harm. Okay. And there is another thing that describes the guidelines or the recommendations that's called as the quality of evidence or the level of evidence. Okay. That is based on how good the study was. Okay. That supported the guideline. So if it's level 1, it is RCTs. We have very few guidelines that is based on level 1 recommendation. I think it's around 1 to 2%. Out of 700 recommendations, only very little has level 1 because as you have understood, it's very difficult to do a randomized controlled trial in CPCR or registration when the patient is actually undergoing registration. It's difficult to do that. And cardiac arrest is divided into 2, which is called as primary and secondary. Primary basically is a problem of the heart. Okay, the typical example is a MI. Then it could be pericardial tamponade. It could be a valvular pathology. It could be myocarditis. Okay, cardiomyopathies. And secondary cardiac arrest is because of some other cause rather than the heart. So it could be, and the typical example is a hypoxic cardiac arrest. And that usually is occurring more commonly in children as well as in drowning victims. So we said that when you check the rhythm, you can classify patients into 2 depending on the rhythm that you see. So everybody should be familiar with the rhythm, that rhythm identification. So we have VF and pulseless VT. See, VT can be either with pulse or without pulse. So without pulse qualifies for the cardiac arrest ECG pattern, whereas with pulse is not cardiac arrest. Okay, and the last 2, that is asystole and pulsus electrical activity, which was early called as electromechanical dissociation, where you don't have a pulse, but there is some electrical activity. So it's so important to always keep a hand on the pulse in very critically, or even the SpO2 would also be useful. So asystole and pulsus electrical activity are non-shockable. Shock will not work there. Okay. So the first one is the totally chaotic ECG pattern where you don't see any kind of P waves or QRS, totally haphazard, no symmetry, and that is VF. VF is always cardiac arrest, okay? Whereas the second one is the VT, and if you don't have a pulse, you call it as cardiac arrest, and it's called as a pulseless VT. The third one is the severe bradycardia progressing to asystole. In pulsus electrical activity, you might have some kind of ECG patterns which you might think as normal, but you will not get a pulse because of electromechanical dissociation. Okay. This is what I said just now to classify patients into shockable and non-shockable. So once it is shockable, of course, your treatment would be to shock the patient. Okay. And we'll call that shock as shock number 1. Okay. And what do you do immediately after giving the shock? See, when you give the shock, many things can happen. 1, it can revert to normal sinus. Okay. Second, it can stay like that. It can stay as VF. Third, it can go to VT or some other rhythm. Okay. So 3 things can occur, but then after the shock, we don't wait to see, or just immediately after the shock, we don't look to see, we don't check the rhythm to see if it has reverted or not. So what we do is that we start CPCR for 2 minutes, okay? And the end of 2 minutes, we see whether the shock that we gave earlier was successful or not. Fine. So that should always be followed. Don't check for rhythm soon after the shock, okay? And we'll discuss why it is done in later slides. So this is a question for you. What is the first step in the management of VF? Suppose you have a cardiac monitor, not a defibrillator. Okay, suppose, and you see that, or you have a defibrillator, we check the rhythm, we see VF. What is the next step that you do? Would you give amiodarone? Would you give a synchronized cardioversion? Would you give an unsynchronized cardioversion? Would you start high quality CPR, CPCR or CPR? Adrenaline push, adrenaline infusion or lignocaine? Can anyone unmute and answer this? we'll have a discussion. Even if it's wrong, we'll see what is happening. So here, amiodarone is a drug of maybe not a choice, but still you can use that for refractory VF, but not initially. Synchronized cardioversion is not used for VF. It is maybe used for SVTs. Unsynchronized, that is defibrillation. Yes, that is one option. Okay, high quality CPR is a very good option. Adrenaline, of course, is an option, but then we already said that defibrillation would be the treatment of choice for VF. Infusion is not at this moment. Lignocaine is also an alternative for amiodarone. So we have two choices, really looking at you: cardioversion, unsynchronized, that is defibrillation, or high quality CPCR. See, imagine you are seeing this rhythm in the ECG monitor. Okay, what would happen? You have to wait. You have to call for help. Okay, you have to have someone, or you go to bring the defibrillator, switch it on, get it charged. It will take time. So meaning during that time, you have to give CPR. So the answer, so suppose if it's a defibrillator itself, you have attached a defibrillator, you find VF. You still have some time for it to charge. And during that time also, you give CPR. So that is the answer. So high quality CR or CPR is the answer. And meanwhile, when the defibrillator is fully charged, you can give the defibrillation. So this is the statement that will substantiate what I said. Defibrillation is most successful when administered as soon as possible. Does not mean that you have to stop your CPCR. Very, very important. See, one of the things that tells you that you have high quality CPR, which of course would translate to mortality or even neurological deficits at the end of your registration, does not mean that. One of the things that tells you quality is good is have minimum stoppages. Interruptions should be minimum. That is one thing that tells you a quality of CPCR is good. So minimizing disruptions in CPR surrounding the shock administration is a high priority. So you should not think of not doing CPCR to bring or to buy time for the defibrillator to come and get it charged. Okay, hope that point is very clear. Defibrillators are of two types. I don't know whether this had been discussed previously. The left side one is the manual biphasic. They have heavy paddles. Okay, paddles. The right one is the automated external defibrillator where you have pads. It is a ECG sticking type of pads. Okay, you can remove the outer cover and then stick it onto the patient's chest. And this is the emblem that tells you the availability of AED at different places. So it might be, I think it's available in Vande Bharat train also. You have this in Lulu Mall, airports, railway stations, malls, all these places, cinema theaters. You should be having this AEDs. Both would have a size of around 8 to 12 centimeters in diameter for adults. And you have a smaller size. So you can just twist the adult probe and then remove the adult probe. You have a pediatric probe that is hidden inside the adult one. So just see how to remove that adult probe. When you remove the adult probe from the paddles, not the pads, okay? From the paddles, you will get the pediatric probe. The size is a bit smaller. Where do you place? It might have been discussed. So you have the anterolateral as the most common. The sternal pad is usually placed below the right clavicle. Okay, just below the right clavicle, and the other one is placed at the apex. Okay, that's called the anterolateral. You also have anteroposterior. Again, we have anterior left infrascapular and right infra. The heart should be in between. That is the only thing. Okay, and all these positions are found to be equally effective to treat arrhythmias. And I told you that we use biphasic wave defibrillators, not monophasic. Monophasic were there previously, but I think most of our hospitals and places where you work would be having biphasic. Okay, so, and we also recommend a single shock. We don't stack the stocks. Panda, we had to give 150, 200, 360, you increase the joule. Okay, so that is not recommended. We only give one shock. And the reason for using a biphasic waveform is that it needs less energy for defibrillation. And using this less energy, you have a greater success rate for the first shock and a greater efficacy. So that is why biphasic is used. And what about single shock? Why are you giving a single shock? Single shock is given because when you use the biphasic, the first shock itself would revert the rhythm most often. And when you give a single shock, there would be less time for stopping of the compressions. And it, of course, had led to better survival. That is the reason for single shock. What is biphasic? It means that the pads or paddles would deliver pulses of opposite polarity. So one would be positive, other would be negative. That is how it's it. And then the next question that comes is here, what is your energy that you use for defibrillation? The correct answer would be a default energy of the defibrillator. And the default energy of the defibrillator would vary between defibrillators. So one defibrillator would have 150, the other one would have 120, and the third one would have 200. How do we find this? In the ventilator that we use here, it is a dial type. You have to select the energy by rotating the dial. And in the dial markings, when you see the numerical that has been written there, when you reach 150, you have an orange box surrounding that numerical. That's the default energy. So 150 is the default energy for our defibrillator that we use in the ICU. And sometimes you might not have a rotating knob. So it might be all electronic. And if that is there, whatever energy that comes first is the default energy. Of course, give the single shock. And if you don't know what is default energy is, give the maximum shock that is available on the defibrillator. Hope that is clear. In case you have an old one, you have the joule energy is 360. Okay. And again, here it is single shock only. What is this? Can somebody identify what this is? See, when you give the shock, there's a rare chance that the shock can take a easy path out. If you are barefoot and you are on water and the resistance that is offered between the paddles and the skin of the patient is very high, this current may take a easy path out. This is I clear, you clear, everybody clear. So just to make sure that nobody is touching the patient, we double confirm and then only give the shock. And as I've told you earlier, immediately after the shock, you start CPCR. Okay, for 2 minutes, that will translate to 5 cycles of 30:2. Why is it done? That's to minimize the no-flow time. Suppose our heart has reverted to sinus and it starts to pump. Even if it starts to pump, it will take some time for the shunt heart to effectively pump blood. It will start to pump, but the pumping would not be very effective. That's called as a no flow or minimal flow time. So to overcome that, we do the compressions during that time. We assume that it will take 2 minutes for the heart to perform well. So again, after 2 minutes, we check the rhythm. If again shockable, we give the shock number 2. And the energy that we use for the shock number 2 is almost the same as the previous one. That's a manual monophasic or AED. Or if you are using a manual biphasic, okay, where you can adjust the energy, you can go for a higher if the ventilator allows, if the defibrillator allows you to. So if it was 150 initially, you can go up to 200. And
1, 2, 3.
The AED has come.
When the AED arrives, put it near the rescuer who will be operating the AED and turn it on.
The other person is giving
The AED
CPCR
turn on,
continuously.
lift the cover. Others have a power button.
Apply pads to patient's bare chest.
The pads are being
Open the
attached.
pad package and peel off the plastic backing. Press the sticky side on the victim's bare chest. Place one pad on the upper right side of the bare chest to the right of the breastbone. Put the other pad a few inches below the left armpit. With 2 rescuers, don't stop CPR until the AED pads are attached to the chest and you are ready to let the AED analyze the victim's heart rhythm.
Plug in pad's connector next to flashing light.
The AED is now ready to check the victim's heart rhythm. Most AEDs begin to check the rhythm as soon as the pads are attached and connected. For others, you press an Analyze button.
Analyzing heart rhythm.
10, 11, 12.
If the AED finds a heart rhythm that could be treated with a shock, the AED will tell you so.
Shock advised. Stay clear of patient. Deliver shock now.
The AED will then tell you when to push the shock button.
I'm clear, you're clear. We're all clear.
When the shock is delivered, the victim's muscles will jerk. The AED will then tell you to start CPR, beginning with chest compressions.
8, 9, 10,
Begin
11,
CPR.
12, 13, 14, 15.
After
So that was a perfect example how to do the shock. And the lady was continuously giving CPR as well as breaths during the attachment of the AED to the patient. And only during the analysis period, you have to stop. Okay. So we are now dealing with a shockable rhythm, and is along with the second shock, you think of vasopressor. The vasopressor that is recommended is adrenaline. Okay. So adrenaline is the vasopressor and maybe the only one that is recommended, and that is effective for all the 4 rhythm types that we get in cardiac arrest. Previously, there was vasopressin. Even 2025 guidelines does not recommend vasopressin as a vasopressor during CPCR. Okay. So what do you do after shock number 2? We do the CPCR, okay, and then check the rhythm. And if it's still shockable, you give shock number 3. Energy is very similar to second shock. So if you have increased, so first you give 150. You have the option to increase to 200, and if you have increased to 200, you can still use 200. Okay, most of the time, the biphasic manual biphasic would have a maximum energy of around 200 joules. And it's with the third shock, you think of drugs that would help you tackle a VF or VT, pulseless VT. Okay, especially amiodarone and lignocaine. So, along with the second shock, we gave adrenaline in a patient who had a shockable rhythm. Along with the third shock, where you think that this is a bit refractory to shock, you start to think of drugs, amiodarone and lignocaine. And we have something which is called as persistent VF bar pulseless VT. Even after the third shock, the patient remains in VF bar VT. And there are 2 types of persistent VF or VT. One is called as incessant. Okay, that is because the shock did not have any action. It could not revert. Okay, what do you do here? You can change the position of the probe, the paddles. Okay, position change when it's anterolateral, you can try a antero-posterior. Okay, where one of the paddles or pads is placed on the posterior part. That's called as a vector change. Another option is double sequential defibrillation, where actually you need 2 defibrillators and 4 paddles or pads, which are like attached or placed. Most of them, they would be attached. Okay, you cannot like have paddles being placed at 4 places. Okay, so it is attached to 4 places, and you give 2 shocks in succession. That means no gap. There is no time for you to charge the single defibrillator. So you actually should have 2 defibrillators. Okay, and that is done in incessant VF, and that is because the shock did not work, did not do the trick it has to. It did not change to normal sinus rhythm. And the second type of persistent VF is called as recurrent, where actually the shock worked, but during the 2 minutes of your CPCR that you do, immediately after the shock, it went back to VF. Okay. In such patients, it would be difficult for us to see whether it is a incessant or recurrent unless you have the continuous monitoring of the ECG. So in such cases, you should use drugs that would stabilize the heart. Okay. It will stabilize the heart to stay in the sinus rhythm rather than going back to the VF. So the treatment of these 2 differs. And the recommendation is may be considered. It's not a level 1, class 1 recommendation. Sorry, class 1 COR is not 1. Okay, may be considered. This is what I said, vector change. First, initially it was androlateral and then that has been switched to androposterior. And the right side picture shows double defibrillation where we have 4 pads that are attached. One is androlateral and the second is androposterior, and you apply the shocks immediately, one after the other. Okay, there is no gap at all. So what are we doing till now? In a patient who has shockable rhythm. I emphasize shockable rhythm. Okay. We gave 2 shocks. Along the second shock, we gave adrenaline. We gave this third shock. Okay. Then we gave amiodarone lignocaine. We gave the 4th shock. We tried epinephrine. And then after the 5th, we again gave amiodarone lignocaine. Okay. So in between, you might have your vector change as well as your double sequence defibrillation coming in. Let's see what happens when our rhythm is non-shockable. You do what you are doing. You start your CPCR again. Okay. And when an intravenous or intraosseous line is present, administer adrenaline. So when you have a non-shockable rhythm, the guideline says that you are justified in giving adrenaline bit early. You don't have to wait till the second rhythm check to give adrenaline. And that was exactly what we were doing here. In our hospitals where in the ward, the patient has a cardiac arrest, you don't have a ECG monitor. We don't have a defibrillator to tell you what rhythm it is. Okay. We started CPCR and we gave adrenaline. Okay. So that is okay for patients who have a non-shockable rhythm. It is okay. But for a shockable rhythm, ideally adrenaline should be given after high quality CPCR and defibrillating. It's along with the second shock you think of giving adrenaline. That is a perfect scenario. We have 2 slides regarding pulsus electrical activity. So basically you have reversible causes like the 5H and 5Ts. And what you do here is that you have to continue your CPCR and then treat whatever you can. Okay, you have to keenly assess whether the patient is having a tension pneumothorax or a cardiac tamponade. Okay, easily reversible. Then hypovolemia is one thing that is reversible. Hypoxia and also acidosis, H plus excess. Problems with potassium and hypothermia. Okay. And this is the 2025 update regarding the access. So in 2020, they said that intravenous is equivalent to intraosseous. But the studies have found that when they gave intraosseous, see, these guidelines are applicable for lay rescuers also, or people who are not doctors or who are not well versed in putting an IV cannula. So problem with this is that when they gave intraosseous, the drug did not work well, and those patients had a bad outcome. So here they very clearly say 1A, level class of recommendation is 1. It should be done. Okay. And what they say here is that IV is better than intraosseous. Yeah, if you don't get IV, you go for intraosseous. That's so first attempt is always intraosseous. Intravenous. Intraosseous is reasonable if the initial attempts at intravenous access are unsuccessful or not feasible, then you can go for an intraosseous for adult patients. That is a class of recommendation and level of evidence. How about a central line? Again, that is not routinely done. You know, even central line is more difficult and you need more trained people. And if you have appropriately trained person, attempts at IV and intraosseous is not successful, you can try that central venous. Okay. But then everything comes at stopping of your CPCR. That should not be done. That is a take home point. Okay. Never stop the CPCR. Either for IV, either for central line, either for intubation. Try to minimize the interruptions. Drug administration via the endotracheal tube, which was advised in the previous 2020 guideline, is not recommended, has been removed from the guideline. Okay. Previously, if you didn't get a cannula or intraosseous route, okay, we would go for endotracheal, but then that is out of question now because they found that the blood concentration that was obtained when you gave drugs to the endotracheal tube was low. We had unpredictable pharmacological effects. So this route of administration has been removed from the 2025 guideline. Intraosseous options are there. You have to have a intraosseous needle, and even a 16-inch cannula would do if you don't have any other resource. So the sites are usually the medial tibia, just below the tibial tuberosity, medial part of the leg, and also medial malleolus in the medial side. So we'll go to drug session. We talked about adrenaline and the dose being 1 milligram every 3 to 5 minutes. Okay. And it's a very high dose. And the questions that would come to your mind is when to give adrenaline. Already talked about that. That depends on whether it's shockable or non-shockable. Non-shockable, you can give it early, it's okay. But if it's shockable, ideally it should be given along with the second shock. How is adrenaline working? It has more of alpha 1. When you give high doses, the alpha 1 action comes in, and you have intense constriction of your major vessels. So the aortic root pressure increases. That is what is going to supply your coronaries. The diastolic pressure increases, and the coronaries are perfused better. Okay. And what is the concentration of undiluted adrenaline? 1 ml contains 1 milligram. So you have to give 1 ml. So when you give 1 ml into the veins where there is little circulation, it will not be pushed into the central compartment. So how do you push it? You have to give a chaser fluid. So 10 to 20 ml of saline you can give as a chaser, so that will go push the 1 milligram of adrenaline that you give into circulation. Second option is to milk the arm or elevate the limb. Okay. So it's always high doses of adrenaline that is recommended. We have class of recommendations level 1. Never give intracardiac. And as per 2025, you don't have much role to give a endotracheal adrenaline also, because intracardiac is avoided because you might directly inject the adrenaline into a muscle, cardiac muscle. Okay. Or even the coronaries. Blood will come when you puncture the coronaries. You might inject that. That would be very hazardous. And we don't, it's not recommended at all. And remember, there is no role for atropine in cardiac arrest. So whenever you write the, what you call CPCR notes, okay, never write atropine. If somebody writes, they are not well aware of what they are doing. CPCR, no role for atropine. Atropine can be used in severe bradycardia only, not in CPCR. Okay. And the vagolytic dose of atropine is around 3 milligrams. As I said earlier, vasopressin has no role in the current guidelines for it being a vasopressor. It's not used at all as a vasopressor. Then we come to amiodarone. Amiodarone is a sodium, potassium, and calcium channel blocker. It blocks all the three. You know, lignocaine is a sodium channel blocker. So if you have both, okay, the first one you would give is lignocaine. It blocks the sodium. Then you give amiodarone. You can give amiodarone, so it blocks the other calcium and potassium. Not the other way around. If you give amiodarone first and then give lignocaine later, lignocaine will not have any effect because amiodarone has already blocked the sodium channels. So this is a mechanism of action: slows the AV conduction, prolongs the AV refractory period, prolongs QT interval, and slows the ventricular conduction. You can give 300 milligram bolus, then 150 milligram. That's a repeat dose. You can give 150 milligram for adult. Lignocaine, the dose is 1 to 1.5 milligram. That should be preservative free. It's not the local that you use for local anesthesia. It's called Silocard, or it should be preservative free. Dose is 1 to 1.5 milligram. Efficacy is almost equal to that of amiodarone. How about soda bicarb? So very clearly it said not recommended for routine use during cardiac. So all patients need not get soda bicarb. And the class of recommendation is 3, not to be used. But then it has very specific indications. As a routine, it should not be used. That is what they say. As a routine for all patients in cardiac, don't give. But when you really think of using soda bicarb is when a patient has hyperkalemia, and that even for hyperkalemia patient, we use soda bicarb. That is a bit out of evidence, but it's not 3. So hyperkalemia, pre-existing metabolic acidosis, and prolonged restation are the 3 situations. And what is prolonged? What is the time? It's not defined, but then you assume that there will be a lot of metabolic acidosis. And remember, metabolic acidosis divided into high ion gap and normal ion gap. And for high ion gap metabolic acid, it's not very useful, soda bicarb. It's more useful for normal ion gap. Remember, soda bicarb is only used after all other interventions fail. Okay. And the dose is easy to keep in mind. Around 50 ml bolus you can give. Okay. And the further doses are guided by your ABG. You have formulas like base excess into 0.3 into body weight. You calculate that and divide by 2, so you get the half of this. You give that and then you do the ABG again and see what is happening. Then come to other drugs like calcium. Calcium again you have can give that for hyperkalemia because you give that as a physiological antagonism. Calcium gluconate. Okay. For hyperkalemia as well as for toxic injections like calcium channel blockers and beta blockers, you can give calcium to counter that. And steroids is not recommended. It has very uncertain benefits for use in cardiac arrest. I think it's very commonly one drug that we give not without evidence is steroids. Bicarbonate, as I said, can be used in patients who have pre-existing acidosis, especially normal ion gap and hyperkalemia. This is the algorithm we have already discussed, and this is a shockable one, and the right side is a non-shockable one. What do you do for non-shockable? You continue CPCR. Would you use your ultrasound machine to do some kind of point of care ultrasound for patients who are like undergoing CPCR? You can do. What all things can you identify when you use ultrasound during CPCR? One is you can identify cardiac tamponade. Very good. Second is a tension pneumothorax. So that we can do the lung ultrasound that is not even near the heart at all, not near the place where you do the CPCR. So if you can use ultrasound and provided it does not interfere with the CPCR, again emphasizing high quality CPCR is very, very important. Don't stop. We only stop for rhythm check. When you change the rescuers, every 2 minutes we change the rescuers. That time also you can think of maybe less than 5 seconds it would take for the change. Regarding how much oxygen that you give during CPCR is the maximum that is available. The maximum that you could give is 100%. So try to give 100% during CPCR. And during doing a ABG during the CPCR is again of uncertain value. And we already talked about the return of spontaneous circulation by seeing the rise in ETCO2 and intraarterial. That is recommended. So you can identify ROSC not just with your palpation of your pulse, but then if you have ETCO2, you can use it. Advanced airway placement is part of your ALS guideline. So till now we can manage. With your bag and mask ventilation. Okay. But once you come to ALS, you think of putting a airway. And the advanced airway is either your supraglottic device like your LMA or the endotracheal tube. Okay. When do you intubate the patient in CPCR? So the answer is when expertise is available. Okay, if you feel you are comfortable in putting the tube, you can. But the other side is more practically important. Don't stop CPCR for prolonged periods in the name of intubation. Okay, so intubation during CPCR, it might be possible for experts to put in a tube when the compressions are ongoing, but then others might find it difficult. Usually stop your CPCR. So that part would be more important. Stopping your CPCR for first attempt, second attempts, that should be avoided at all. So it should be totally avoided. Stopping your CPCR for repeated trial for your intratracheal intubation should be avoided. And your placement should not interrupt your chest compressions. And capnography is one of the most reliable method to identify that the tube is inside the trachea and not the esophagus. Again, very important. Supraglottic airways has been acceptable, and especially for out of hospital cardiac arrest. You have the team going in, there might be not experts in. I think everybody should be able to, like, it does not need any equipment. LMA insertion does not need any equipment, and that can be done very easily. So that is in the guideline. So there's no harm in doing that. And once you put in the airway, so till now we are doing like 30:2, right? 30 compressions and 2 breaths till now. And once you put in the airway, the rate of the ventilation or breaths would be 10 per minute. So that's 1 breath every 6 seconds. And the tidal volume, hope you know, just to have a visible chest rise. So what are the scenarios where you don't start CPCR, especially the out of hospital cardiac arrest? One is easy to say, where you have a valid DNAR order. There are a lot of changes in the legislation in India where like you can put in these things saying that I don't want to be restated. You can. That is legally valid, provided it's done in the proper way. That is a bit cumbersome, but still, if you can put up the legal document. They are not supposed to do a registration. Okay, so what is DNAR? It is do not attempt registration. What is AND is allow natural death, almost having the same meaning. And usually have a bracelet showing that it is DNR, because you might not be conscious to say that do not restate. Okay, or unless you have a bystander telling the people not to restate. Second scenario where you don't start CPCR, where you have signs of irreversible death, rigor mortis, levatus reticularis. The muscles are all very stiff, and decapitation, yes, decomposed body, decapitation. That's all signs of irreversible death. So when you have a person bringing a patient who is not moving, and you actually don't know the time of cardiac arrest, it's difficult. Once you bring the patient to the hospital without CPCR again, you can ask her how much time it took for the patient to reach the hospital. What is the time of actual time when the patient was found unresponsive? Was it witnessed? And based on all these things, you can think of starting CPCR. And the third one would be our risk. Okay, so don't jump into water if you don't know how to swim. Very, very important, because we are hearing news that the person who was trying to rescue the other drowning victim, 2 of them died. And the victim person who drowned first would survive also. So if the rescuer is at risk of serious injuries, please don't go into start CPCR. Be safe. And doing CPCR in the middle of the road where you would be having a chance of being hit by the car that is coming next would be again a serious risk. Then next question that comes to your mind is when to stop your CPCR. Okay, we have different guidelines. BLS stopping is different and ALS stopping is different. So when to stop when you are doing the basic life support. Okay, and most of this might apply to patients who have a out of hospital cardiac arrest, OHCA. So let's see when you stop your CPCR, when you are just doing the BLS, not advanced. Arrest not witnessed by emergency medical service. So when you reach the spot, the patient already had the cardiac arrest. There could be another scenario where you were called in to treat a patient who's really ill, and then over time, when you were there, the EMS was there, the cardiac arrest occurred. That is witnessed. So that is not, this scenario is not that. You don't know when the patient actually had. We didn't see that. Okay. And there is no return of spontaneous circulation before transport. So you did your BLS, but then there is no ROSC attained. And no AED shock was delivered before transport. Either it was not indicated. Most of them, it was a non-shockable for them. So it was not indicated. The AED shock was not delivered. And all the criteria met, and you can stop. If any of this is met, you have to continue. And you have to think of transport to the hospital. And this might not be appropriate for patients with toxicity overdose of drugs, trauma patients, or in-hospital cardiac arrest. So basically, this is OHCA. Here we did not see, EMS person did not see, no return of spontaneous or no ROSC before transport, and no shock was delivered. Whereas termination of registration in ALS guideline, that is again OHCA, arrest is not witnessed. That is different from what we saw in the previous slide. This is not witnessed by anybody. So most of the time, you have people identifying patient not moving when they wake up. At early morning, they go to the room and knock. A person is not waking up, but actually you don't know what is the time of the arrest. Okay, no bystander CPR was done, and no return of spontaneous circulation before transport. Again, this is out of hospital, and no shock was delivered. If all the criteria are met, even the ALS team can decide on stopping. Okay, so that is, if any of this is there, you have to continue and decide on transportation. So this is what I just said now. There's something called as a universal termination rule, which can be applied to BLS patients, and we have the ALS guideline. We discussed that. What happens when you are doing CPCR in hospital or in the ICU? If you don't have a DNR, if you have a DNR order, you actually don't start. But in case you have started and you later come to find that the patient is having a DNR order, you can stop this CPCR. And during the CPCR, the treating physician decides. Okay, and that decision is based on whether was it witnessed or unwitnessed. Maybe you have the patient in the hospital, but then he's gone to the toilet where he collapsed. Okay, and it was not witnessed. And see, you always have a better prognosis for witnessed arrest. Time to CPCR is another. How much time, the gap between the collapse or the arrest and the CPR. Initial arrest rhythm. So you have better prognosis for VF and pulseless VT rather than asystole. Time to defibrillate is so very important for shockable rhythms. So you have a patient who loses 1 minute for defibrillation, the mortality increases by 7%. Every minute you lose to defibrillate, the mortality increases by 7%. The comorbid state the patient has, especially like multiple malignancies or spread out malignancies, ROS can sometimes. So when you have the return of spontaneous that occurred sometime, that it went back to cardiac arrest, then you can think of continuing your CPCR. Then we have, sorry. So you might have understood that this is a mechanical compression device. Okay, mechanical device. So what is the recommendation as per the 2025 guideline? There is no evidence of improved outcome in manual CPR in either out of hospital or in hospital. But this can be considered in specific settings where the delivery of high quality manual compression may be challenging or dangerous. So one typical example is a patient who is having cardiac arrest inside the cath lab, where you have all the CM and things like that, and you find it difficult to do the CPCR there. So there you can use, and during transport also. Okay, the hands, the video would we'll feel that the patient is doing the compression because the hands are held like that. It's not that the hands are actually attached to the that is how the hands stay when you attach this device. Then you have something called as the eCPCR or CPR, where you go for ECMO, extracorporeal, and that is done extensively in other countries like Singapore and places where this is quite common. So which all patients would we select? Okay. The most important thing is that the disease process should be potentially reversible within a few days. Okay. During a limited period of mechanical cardiorespiratory support. Such patients, typical examples are amniotic fluid embolism. Yes. We have myocarditis. Okay, so these are patients where you think of eCPCR. And one slide regarding pregnancy. You have an algorithm. Most of the things are very similar to what we do for standard adults. One thing is that because of the uterus pushing up the diaphragm, you may opt for a bit higher position for compression. Again, high quality CPCR is recommended. And one word that they modified was, it's now reframed as restated delivery. Okay, restated delivery. Previous it was perimortem cesarean, things like that, or it was restative hysterotomy. Basically, it's a restated delivery within 5 minutes. So that is one major change. What they recommended was, the previous guideline was, you start to think of this delivery at 4 minutes and then complete by 5 minutes. In a minute, it would be very difficult. So in 2025 guideline, what they recommend is to start thinking of delivery, restated delivery, the moment you diagnose cardiac arrest. That is interesting. The moment you identify cardiac arrest in a pregnant patient, you think of doing this, and that should be completed within 5 minutes if there is no ROSC. Okay. And never forget your manual your lateral uterine displacement. Okay. That can be done with our hand. And here, especially for amniotic fluid embolism and things that occur, which are easily correctable, you can go for extracorporeal CPR. The IV access ideally preferred above the diaphragm because you have the uterus compressing the IVC. They always have a little reserve, and early intubation is always recommended using a smaller tube because the airway would be smaller. And most of the time it would be done to save the mother. This is the lateral uterine displacement. You can either pull or push. Okay, using depending on where you stand. You can use 2 arms to pull or 1 hand to push. And a massive transfusion protocol with a balanced, that is specifically for amniotic fluid embolism. Because these patients would have DIC and a lot of blood loss. They asked to start a massive blood transfusion protocol, but then also say that with a balanced transfusion strategy. So you have to do all the hemoglobin and the test, maybe point of care, TEG and all those things to decide how much blood transfusion we need. And tranexamic acid should be administered to peripartum patients with life-threatening suspected amniotic fluid embolism. So that is again recommended with class of recommendation 1. Okay, so these are the major changes for pregnancy CPCR. And they have been mentioned for organ donation also in this guideline. I think it's new. It's a new one. Which, see, you have something called as the donation after cardiac arrest. You have donation after neurological death by neurological criteria and death by cardiac criteria. So, so in those patients where your CPCR is ineffective and you have the patient being declared dead, that's the moment you can think of activating the organ. Maybe you might have to activate earlier, but still see if this something can be harvested, even the cornea or something. So that also should be taken into consideration depending upon the local rules and regulations that prevail in where you work. So we'll talk a bit about post-cardiac arrest care. So how to stabilize? See, return of spontaneous does not tell you that the patient is stable. You have to stabilize the patient further. Okay. And how to stabilize and what was the cause of the arrest? Should I shift the patient to an ICU to have post-cardiac arrest care? Is any cardiac intervention needed? What are the ventilatory goals? Is hypothermia needed to protect the brain? When should I wake up the patient? And when and how to prognosticate? So how to stabilize is you probably would be having an IV line. And because you always need very constant monitoring and specialized care, you have to shift the patient to an ICU. Monitoring all the basic monitors as well as the ETCO2 and advanced monitoring might be needed depending upon the status of the patient. You can give IV fluids to stabilize the patient even after cardiac arrest. Patient might be hypovolemic. Vasopressors, again, any kind of vasopressor you can use. Again, that again depends upon the hemodynamic monitoring. NORAD would be preferred in most of the time. And if it feels more of a cardiogenic shock, you might think of adding dobutamine if the BP is like not very low. And most of the time you convert to your endotracheal intubation. Even patient was not intubated till now, you have to intubate. Supraglottic airway device, it might be difficult to ventilate patients with the LMA. Most of the time, you would convert to endotracheal tube. And if the patient just recovered from VF bar pulse VT, you might think of continuing your amiodarone and things like that. Causes, as you know, it's cardiac hypovolemia, respiratory drugs, electrolyte problems, CNS insults, and sepsis. So these are major cause of cardiac arrest, and you have to identify the cause and treat. If you don't treat, it will recur. That is the problem. So if you don't treat the cause of cardiac arrest, it will come back again. If you don't treat acidosis, it will come back again. If you don't treat hyperkalemia, the cardiac arrest will come back again. Workup is, of course, essential to identify the cause of cardiac arrest. Troponin, again, most of the time it would be invariably positive because we did the cardiac massage, and it would be difficult to differentiate between a troponitis of cardiac arrest compressions versus a STEMI or NSTEMI. Toxicology is one thing you keep in mind. Okay, and then what are our goals? Ventilator goals is eucapnia. The carbon dioxide should be almost in the normal range, around 40 to 50, unless the patient has severe acidosis. Okay, and because why is this? The answer is that the carbon dioxide would affect your cerebral perfusion. Okay, so if it is higher, the cerebral blood flow would be higher and the ICP can go high. SpO2 9, I think it's, as per 2025 recommendations, 90 to 98% is okay. So anything more than 94 is well accepted, and PO2 is around 60 to 105 millimeters of mercury. Again, that is a 2025 guideline. MAP should be more than, MAP is mean arterial pressure should be more than 65. You adjust your vasopressors like that. This algorithm is 2025 algorithm. So you have to usually put in an airway device, especially the endotracheal tube, and confirm that it's there. You maintain your saturation between 90 to 98 and a PO2 of around 60 to 105. Again, you might not need 100% oxygen here. So during the cardiac arrest, you give 100%, but post cardiac arrest, you have the time to titrate your oxygen to a SpO2 of around 90 to 98. And carbon dioxide targets again almost normal. And 5 to identify the cause. So if STEMI is persistent, okay, and the patient is having unstable cardiogenic shock, which you would be able to identify with the echo, and the patient is already on mechanical circulatory support, you think of emergency cardiac interventions. Okay, so whether to have the temperature control, targeted therapeutic temperature, or targeted temperature management, which is more perfect, a TTM. So that's a targeted temperature management. So that is decided based on how awake the patient is. After your CPCR, you ask the patient to do some obeying commands. Okay, if the patient is obeying, there's no need for TTM. Whereas if you are not sure, or if he's not obeying, you think of going for temperature control, and both would have ongoing critical care. And you think of a EEG also, the patient is not awakening, to rule out a non-convulsive status. Coronary angiogram, if the cause of arrest is a STEMI, you have to go for that. And prognostication is always multimodal. You don't use a single parameter like a pupil reaction not there at 48 hours. It's just a single parameter. Like the GCS, the motor score, whatever. If you don't use a single parameter to prognosticate, you always have to have multimodal prognostication. Okay. You might have to give 1 to 2 liters of cold saline to cool the patient. And avoid hyperthermia at any cost. That is again very important. Any fever should be very actively managed. Okay. So your vasopressor or inotrope would depend upon the hemodynamics of the patient. Most of the time, NORAD would be the drug of choice for undifferentiated shock. But think of adding dobutamine if the patient has cardiac shock, and your goal is MAP of more than 65. So what are the indications for cardiac interventions? Persistent, I think we already said, cardiogenic shock. You have a ST elevation, refractory arrhythmias, and severe myocardial ischemia. What do? You do a PCF for STEMI. And there are other options like mechanical support. You can go for a VA ECMO. If the ACS is refractory, you have a pulmonary embolism. Again, that is one situation where you think of eCPR. You have the option of intra-aortic balloon pump and ventricular assist devices. Coming to the temperature management, the current recommendation is temperature between 32 to 37.5 for not for 24 hours, but for 36 hours. Earlier recommendation guideline was 24 hours. Now it has been increased to 36 hours. They don't recommend for pre-hospital cooling and also recommend for actively prevent fever. So aggressively treat a fever, and that this temperature management is still done for patients who don't follow commands after the return of spontaneous circulation. And it be out of hospital, in hospital, any rhythm you can go for TTM if the patient is not following commands. But then the level of evidence varies for in-hospital cardiac arrest. And you have to treat the apparent seizures, and where the EEG would play a major role to identify patients who have non-convulsive status. But prophylaxis is not recommended. Okay, you have to take a EEG and see if the patient. And coming to the sugar control, it's 2025 asks you to avoid anything less than 65 and more than 180. Previous guideline, the recommendation was 140 to 180, and that is what we follow for most of ICU patients. So not too low, not too very high. This is the recommendation for adults. Steroids we already talked about. And when do you prognosticate? It's usually done at 72 hours or on the 4th day. 3rd to 4th day is the time you prognosticate. Okay, and that is multimodal. And what are things that decides whether the patient will make it or not is the downtime. Downtime is how many time, what was the duration of CPCR. And the rhythm during PCR, though these are considered to be markers of prognostication, but they are very unreliable. Neurofilament light chain, that is one thing you do as a lab investigation that has evidence to be used as a prognosticating indicator. So when you do the post-cardiac arrest sedation, you always avoid drugs that accumulate, like midazolam, which has an active metabolite. So better options would be propofol and dexmedetomidine, which has a very short context-sensitive half-life. Low-dose ketamine can also be used. Always keep in mind that there might be a non-convulsive status, and apparent frank seizure also should be treated. More rapid improvement. So next day patient looks at you, he moves his limb. That such patients might have a better prognosis, carries a better prognosis. Prognostication is usually done at 72 hours. You can use the MRI to quantify the extent of hypoxic ischemic injury, and the CT might not be a very good investigation to quantify hypoxia. Functional test is the typical clinical examination, EEG, SSCPs, and malignant clonus things would prognosticate. This is the neuroprognostication, clinical examination, EEG, which again continuous is preferred after 24 hours, maybe the most helpful. CT scan, MRI, then SSCP, and you can see the timeline at the lower end of the screen. MRI usually taken as 2 to 7 days to quantify the extent of brain damage. So chances of neurological recovery, depending on the timeline, any patient who is on coma or even after 72 hours has less chance for neurological recovery. And coma for more than 2 weeks, no chance at all. And though the pupillar response and things might not be very ideal, the pupillar response may be an optimistic sign at 24 hours, a positive pupillar response. After 72 hours, if there's no pupillar response, it's a poor outcome. Absent gag reflex at 48 hours is also a poor outcome. So again, the recommendation in 2025 is you have to don't stick on to one parameter, you have to be always multimodal. I have two nearest scenarios where, again, this is part of the ALS guideline. We'll stop in another 10 minutes. Wide complex tachycardia and narrow complex. So when do you say it's wide complex QRS more than, the rate is more than 150 and the duration is more than 120 microseconds. The most common rhythms that occur are VT and VF. You might also have a supraventricular tachyarrhythmias with aberrant conduction, producing a wide complex. And wide complexes are broadly divided into monomorphic and polymorphic. Okay. It's also divided on depending upon the hemodynamic stability, as hemodynamic stable and unstable. Usually, the systolic BPs would be less than 80 in a patient who is hemodynamically unstable. and there will be altered mental status. There is a table showing how to go away, and you have synchronized cardioversion is recommended for acute white complex tachycardia. So here the patient is not in cardiac arrest. That is the main difference. And the second is synchronized cardioversion is recommended for acute with stable white complex tachycardia when vagal maneuvers and pharmacological therapy is ineffective or contraindicated. So when the patient is hemodynamically unstable, go for cardioversion, synchronized. Patient is stable, but then you have done the vagal, you have done with the pharmacological therapy, it's not working, you go for cardioversion. So white complex tachycardia, unstable, that is just what I said. The other things, when this patient is stable, try a vagal, you give drugs and then you go for synchronized cardioversion. Drugs are amiodarone, procainamide, beta blockers. Adenosine is, adenosine is especially used for narrow complex tachycardia. And if you suspect this being a SVT with accessory pathway, you can still use adenosine. Verapamil and lignocaine. One of the drugs that we commonly use is amiodarone. So this patient, again, I emphasize, it's not in cardiac arrest. So when you talk about synchronization and unsynchronized, you have the sync button. So this is biphasic defibrillator with, you can use it as a synchronized one also. So you have to press the sync button when you want to sync. And what does sync do is that, like, it will try to avoid the shock being given on the QRS wave, which will produce something, it might change to VF. Okay, so when you shock for VT, it might go to VF. That's the problem when you have R on T phenomena. Okay, so what about polymorphic VT? So we saw that the monomorphic VT had almost the waveforms were looking similar, but here we have a polymorphic VT. A typical example is Torsady point, and here it's like twisting around the axis. So you can see the ECG very typically, and here this polymorphic VT are considered hemodynamically and electrically unstable. So the answer, your treatment is always shock. That is unsynchronized shock, because you don't have a typical QRS where the machine would be identifying the QRS. That is not there. So you cannot sync here. So you always give a unsynchronized shock for polymorphic VT. And you might think of magnesium also if you have a Torsady point. Coming to narrow complex, the treatments will include vagal maneuvers. Adenosine, again, is the drug of choice, but it's contraindicated in bronchial asthma. Unstable, any unstable, you could straightly go for synchronized cardioversion here. Stable but not responding, again, that is an indication for cardioversion. Diltiazem, verapamil for stable, and also beta blockers can be given. So whenever you give the cardioversion, give some sedation like midazolam or fentanyl before you do that. Okay, these are the algorithms for tachycardia. Last slide would be bradycardia. So when you have symptomatic, you try to evaluate and find the cause. Atropine vagolytic is up to 3 milligrams. So you can give increments of 0.6 or 1. And when it's refractory, think of transvenous pacing. And when the other drug option that we have, the patient's not responding to atropine is dopamine, epinephrine, and also transcutaneous pacing. That's not venous, but transcutaneous pacing. But then if you don't have an IV or interosseous line, you can straight away go for a transcutaneous pacing. Immediate transcutaneous pacing can be considered here. So I think I've covered most of the 2025 ALS guideline. So if you have any things to share or add on, it's welcome.
Thank you, sir. Thank you very much. Participants can class എല്ലാ അപ്ഡേറ്റും കവർ ചെയ്തിട്ടുണ്ട് സാർ. അതായത് പാർട്ടിസിപ്പൻസിന് അൺമ്യൂട്ട് ചെയ്ത് ക്വസ്റ്റ്യൻസ് ആസ്ക് ചെയ്യാം, അല്ലെങ്കിൽ ചാറ്റ് ബോക്സിൽ ടൈപ്പ് ചെയ്യാം. ചാറ്റ് ബോക്സിൽ 2 ക്വസ്റ്റ്യൻസ് വന്നിട്ടുണ്ട്. വാട്ട് ഈസ് കാപ്നോഗ്രാഫി എന്നാണ് ഒരു ചോദ്യം.
ക്യാപ്നോഗ്രാഫി എൻടൈറൽ കൗണ്ട് ഓക്സൈഡ് നോക്കുന്നതിന്റെ ട്രേസ് ചെയ്യുന്നതിനാണ് ക്യാപ്നോഗ്രാഫി എന്ന് പറയുന്നത്. എൻടൈറൽ കൗണ്ട് ഓക്സൈഡ് മോണിറ്റർ നമ്മൾ എൻഡോട്രക്കിയൽ ട്യൂബിൽ കണക്ട് ചെയ്യാം, അല്ലെങ്കിൽ നമുക്ക് മാസ്കിൽ കണക്ട് ചെയ്യാം. Both of them would give you the carbon dioxide that is coming out through the exhaled gases, and that would be the maximum at the end of exhalation. That would reflect what is there in the alveolus. അപ്പോൾ alveolar carbon dioxide വരുന്ന എവിടുന്ന്? ഹാർട്ട് പമ്പ് ചെയ്ത് റൈറ്റ് ഹാർട്ട് പമ്പ് ചെയ്ത് alveolar എത്തിക്കണം. So it is an indirect evidence of how good your heart is. And wow, is atropine only
Is atropine only indicated in brady?
Yeah, it is. It is not used in cardiac arrest. Don't mention cardiac arrest. Don't say that you gave atropine. That tells you that you are not familiar with the guideline. It has no role. Of course, we never talked about adrenaline. We have severe bradycardia. You can give adrenaline. Maximum dose you give is 3, and after 3 doses, you see that it is refractory to. Say it's refractory, it's not working. It is like you have to change to dopamine or adrenaline or go for pacing.
പാർട്ടിസിപ്പൻസിന് അൺമ്യൂട്ട് ചെയ്ത ക്വസ്റ്റ്യൻസ് ആസ്ക് ചെയ്യാം, അല്ലെങ്കിൽ ചാറ്റ് ബോക്സിൽ ടൈപ്പ് ചെയ്യാം. ഒരു ഇന്ററാക്റ്റീവ് സെഷൻ ആണ്. തീർച്ചയായിട്ടും അൺമ്യൂട്ട് ചെയ്ത് ചോദിക്കാം നിങ്ങളുടെ സംശയങ്ങൾ.
ECPCR is extracorporeal.
What is ECPA?
Extracorporeal CPR where you use the ECMO machine. Singapore, it's very common now. And I specifically said that is used for patients who have a reversible See, it can be used as a bridge for transplant, but then if it is reversible, like myocarditis, or 2-3 days rest, if it is like, and this is, you have specific indications when you activate the eCPR. When the ROSC is not being attained in spite of you giving perfect CPCR, you think, and you probably know the diagnosis it being something that is very reversible, you think of doing this eCPCR. Broad criteria is again very difficult. You have to take a detailed history. You, as I said, do not restate guidelines scenario would apply there, where you think of seeing the signs of irreversible signs of death, livid color change, rigor mortis, and then just try to elicit a probable time. Because see, when to stop CPCR, Emergency Physicians Association has given a guideline. Like when you do everything properly, all things are done perfectly, and there is no return of circulation at 20 minutes, you think of stopping. Okay. Other that can very well be applied here. So he was found unconscious, is not moving, is not breathing. You get a very clear history. And he is taken to the hospital, which is almost 40-45 minutes. And during that time, no CPCR was done. That patient is unlikely to respond to a CPCR. Okay. And he is likely to have a very severe insult in his brain, because the brain is the number one cells that would have hypoxemic damage very fast. So it would depend on the scenario. Broad dead patients, timing which So if the person had started CPCR, then you have to continue. At the scene, bystander has started, and then the ambulance people started CPCR. It was done during the transportation. You are sitting the casualty, you have to continue that CPCR and then go ahead and think of. That is what the Western guidelines, they have the facility to like give everything perfectly at the site, which is maybe not possible in our scenario, because ambulance people might not have all the drugs. And what they recommend is, if they have the right to stop CPCR there. That is interesting. So such patients will not come to our hospital or casualty.
Sir, another question: if there is dilated pupil, is CPCR indicated?
See, again, like a single thing that tells you that it could be a irreversible sign of death should not be like taken as a criteria not to start CPCR. But there are other signs that tell you like irreversible signs of death. That is what they say, not to start CPCR. But a single dilated pupil would not be. You should also inquire about the time. It might be difficult, and whether the people had done the CPCR. And if that is so, if you are like forced to do a CPCR, make sure that you stop it at a particular time. Okay, maximum you do is 20 minutes. Even that might be very a long period. You try for 1 or 2 cycles and then you can stop. If you really feel that the time gap the patient had from cardiac arrest to the hospital is high, then I think it's better not to start, or you start but then you give a 1 or 2 dose of adrenaline, see the rhythm would most probably would be asystole. Patient will not remain in VF for prolonged period. The VF would gradually fade and go to asystole. Okay, so asystole and you give 1 or 2 cycles of CPR, patients not you can stop early. Don't try to restart such patients for prolonged periods. Most of the patients that come to our ICU are having severe hypoxic ischemic encephalopathy. That is the sad part. And regarding this training of small your class, maybe people who are less than studying less than 10 standard, okay. What the 2025 guidelines then that should be done, okay. But then that is not to make them do CPCR, but just to improve their like interest in studying CPCR when they grow up. So likewise, you have a lot of emphasis on training in the 2025 guideline. Training and ethics also. Equality is being emphasized. Equality. Some patients get CPCR being done, others don't.
One question is not clear. Safety of amiodarone.
Amiodarone is one drug that is useful in refractory VF. Okay, so I said we think of adrenaline with the second shock. We think of amiodarone with the third shock, because just giving the shock would not treat when you have a refractory thing. Safety of amiodarone is the question was asked because the amiodarone is one drug that can produce hypotension. But it's very clearly mentioned that you have to give 300 milligram. It's given as a bolus, but then you can take some time to give. In cardiac arrest, what they recommend is to give as a bolus 300 milligram, and the second dose you can repeat once more. That is 150. It is recommended. While giving shock in unstable SVT is a risk to get into VF. Unstable SVT. There could be chances, but then that would be less. SVT is above, no. So it going into a VF, it would be less.
പാർട്ടിസിപ്പൻസിന് അൺമ്യൂട്ട് ചെയ്ത് നേരിട്ട് ചോദ്യം ചോദിക്കാം, ഇല്ലെങ്കിൽ നമ്മൾ വൈൻഡപ്പ് ചെയ്യുന്ന കാര്യം വൈൻഡപ്പ് ചെയ്യാൻ പ്ലാൻ ചെയ്യാം. ഇങ്ങനെ BLS കഴിഞ്ഞ് 1 മാസം ആയതുകൊണ്ടായിരിക്കും തോന്നുന്നു ആൾക്കാര് ഒരേ പാർട്ടിസിപ്പൻസ് തന്നെയാണോ എന്ന് അറിയത്തില്ല.
BLS 2025 ഗൈഡ്ലൈൻ വന്നിട്ടായിരുന്നല്ലോ നവംബറിൽ.
വന്നിട്ടായിരുന്നു. അതെ, വന്നു കഴിഞ്ഞിട്ടാണ് എടുത്തത്.
BLS is very important to like have a very good brain at the end of your registration. When to start, don't waste time, quality, position, your elbows locked. അതൊക്കെ വളരെ വളരെ ഇമ്പോർട്ടൻ്റ് ആണ്. Ineffective CPCR is like having vegetative patients and
സാറിന് ഒരു ഇൻട്രസ്റ്റിംഗ് ക്വസ്റ്റ്യൻ വന്നിട്ടുണ്ട്. In practice, how to train and improve the quality of care in emergency department in a taluk hospital setup where only a CMO is available?
See, training, retraining. You have your all the algorithms and things stuck up. See, every disease process, every emergency thing has a protocol. Okay, so most of the time we find that that is not being done. ഒരു CVA വന്നു, അല്ലെങ്കിൽ ഒരു MI വന്നു, അല്ലെങ്കിൽ ഒരു ഹൈപ്പോഗ്ലൈസിമിയ വന്നു, അല്ലെങ്കിൽ ഒരു ട്രോമ വന്നു. There is a protocol. So if we can, I think we are all capable of understanding what these guidelines tell you. We don't need further like qualifications to understand this. Only thing is that we are not putting the effort to see what the guidelines are and not putting effort to follow the guidelines. It is very simple. So എല്ലാത്തിനും ഗൈഡ്ലൈൻസും ആൽഗോറിതം ചാർട്ട്സും ഉണ്ട്. You can have all these exhibited in your casualty place. Quality of care. You don't have another person to help you. So what you can do is you can train non-medicals. You can train sisters to have training, reading, training, and following. This is what I would advise. Yeah, we don't dilute. We don't dilute.
അഡ്മിനിസ്ട്രേഷനുമായിട്ട് ബന്ധപ്പെട്ട്
കേട്ടില്ല.
അല്ല സാറ് ട്രെയിനിങ് തന്നെ മാർഗമുള്ളൂ. ട്രെയിൻ ചെയ്യുക, അഡ്മിനിസ്ട്രേഷൻ വീണ്ടും ട്രെയിൻ ചെയ്യുക. ഹോസ്പിറ്റലിലുള്ള എല്ലാ സ്റ്റാഫും ട്രെയിൻഡ് ആയിരിക്കണം. റീട്രെയിനിങ് വേണം. മന്നക്കുനെ തന്നെ ട്രെയിൻ ചെയ്യണം. നമ്മൾ ചെയ്ത് നമ്മൾ ഇമ്പ്രൂവ് ചെയ്യും. അത്
തീർച്ചയായിട്ടും
ഒരു CMO ലീഡ് ചെയ്ത് ബാക്കി സ്റ്റാഫും അതുപോലെ സിൻസിയർ ആയിട്ട് ശ്രമിച്ചാൽ മതി. ട്രെയിനിങ് തന്നെയാണ് ഇമ്പോർട്ടന്റ്. സാറ് പറഞ്ഞ പോലെ ഗൈഡ് ലൈൻ ഉണ്ട്. അത്
ഇതില് ഞാനൊരു കാര്യം ചോദിക്കട്ടെ, ഒരു സ്റ്റാഫ് നഴ്സിന് ഇന്റിബേറ്റ് ചെയ്യാൻ ഒക്കായ്മയുണ്ടോ? ഇഫ് ദേ ഡു ഇറ്റ് ഓൺ എ റെഗുലർ ബേസ്, ഓർ അറ്റ്ലീസ്റ്റ് ദേ ലൈക്ക് യു ഗിവ് ദം. ഞാനൊരു എക്സാമ്പിൾ പറഞ്ഞതേ, നോട്ട് ദാറ്റ് ഇപ്പോൾ ഒരു IV കാനിൽ ഇടുന്നു, അല്ലെങ്കിൽ CPCR കൊടുക്കുന്നു, അവർ ചെയ്തുകൂടാതൊന്നുമില്ലല്ലോ. അല്ല, അപ്പൊ അതുപോലെ ഒരു എഡ്യൂക്കേഷൻ എന്തായാലും ഡെഫിസിറ്റ് ആണ്. പിന്നെ നമുക്ക് അറിയാവുന്ന കാര്യം നമ്മൾ ആരുടെ പറഞ്ഞു കൊടുക്കൂല. അതിന് ഒരു താല്പര്യം കാണിക്കലോ, ഒരു അടുത്ത ആളെ ട്രെയിൻ ചെയ്യാനുള്ള താല്പര്യം എന്തോ ഒരു തെറ്റുപോലാണ്. അവർ ട്രെയിൻ ചെയ്ത് അവരും ചെയ്ത് വരട്ടെ. പ്രാക്ടിക്കൽ സ്കിൽസ് ആർ ലൈക്ക് ഈസി ടു അക്വയർ. വി ഡോണ്ട് നീഡ് തിയറി വേണം ഒരു IV കാനിലിട. വൺസ് യു കുറച്ച് വേണം, വേണ്ടെന്ന് പറയുന്നില്ല, പക്ഷേ വൺസ് യു ഗോ ഓൺ പുട്ടിങ് ദ IV കാനിൽ, യു ക്യാൻ ഡു ദാറ്റ്. എനിബഡി ക്യാൻ ഡു. ഇപ്പം ഒരു MBBS ഡോക്ടർ തന്നെ IV കാനിൽ ഇടണമെന്നോ ഇല്ലല്ലോ. ഇപ്പൊ ആരും ഇടാറില്ല, അത് വേറെ കാര്യം. മനസ്സിലായി? ഇപ്പൊ MBBS ഡോക്ടേഴ്സിന് ആർക്കും IV കാനിൽ ഇടാൻ അറിയില്ല, ബിക്കോസ് അവര് ബ്ലഡ് എടുക്കുന്നില്ല. ഹൗസ് സർജൻസി സമയത്ത് ദേ ആർ നോട്ട് ലെറ്റിംഗ് ബ്ലഡ്. ഇൻവെസ്റ്റിഗേഷൻസിന് വേറെ ആൾക്കാർ വന്നാണ് ബ്ലഡ് എടുക്കുന്നത്. അപ്പം ദേ കനോട്ട് പങ്ക്ചർ എ വെയിൻ ഈവൻ വിത്ത് എ നീഡിൽ. അപ്പൊ അതുപോലും ചെയ്യാത്ത ആൾക്കാർ IV കാനിൽ ഭയങ്കര പാടാണ്. അപ്പൊ ഡോക്ടേഴ്സ് IV കാനിൽ ഇടുന്ന വളരെ കുറവാണ്. അപ്പൊ അതാ ഒരു താല്പര്യം വേണം സാർ. ഇത് ഇമ്പ്രൂവ് ചെയ്യണമെന്നും അത് നമ്മൾ ബാക്കിയുള്ളവരെ ട്രെയിൻ ചെയ്യണം, നമ്മൾ ട്രെയിൻഡ് ആവണം, നമ്മൾ കറക്റ്റായിട്ട് ചെയ്യണം. അതൊരു ഇതില്ലാതെ ഇപ്പം ഉള്ളതുപോലെ പോയാൽ മതി എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ അത് അങ്ങനെ പോകും. പക്ഷെ അതായിരിക്കും അത് നല്ലൊരു ആറ്റിറ്റ്യൂഡ് അല്ല. There is scope for improvement everywhere.
ട്രെയിൻ ചെയ്യണം. വെളിയിൽ EMT തന്നെ ഇന്റിബേറ്റ് ചെയ്യുമല്ലോ. ഒരു ആംബുലൻസ് വരുന്ന സമയത്ത് തന്നെ ഇന്റിബേറ്റ് ചെയ്യും.
പിന്നെ LMA ആർക്കും ഇടാമല്ലോ. സ്കോപ്പ് പോലും വേണ്ട LMA ഇടാൻ. നമ്മള് കംപ്രഷൻ കൊടുത്തിട്ട് ഓക്സിജനേഷൻ ബ്ലഡ് കൊടുത്തില്ലെങ്കിൽ എന്തോ ഒരു കാര്യമില്ല അല്ലേ? കംപ്രഷൻ കൊടുക്കുന്നു, പക്ഷെ ഓക്സിജനേഷൻ ബ്ലഡ് കൊടുക്കുന്നില്ല. ഡീഓക്സിജനേറ്റഡ് ബ്ലഡ് കൊടുത്തിട്ട് വല്ല കാര്യമുണ്ട്?
ഹൈ ക്വാളിറ്റി CPR കൊടുക്കാൻ എല്ലാ സ്റ്റാഫിനെയും, സെക്യൂരിറ്റിയും, അറ്റൻഡറെ, നഴ്സിംഗ് അസിസ്റ്റന്റിനെയും, സ്റ്റാഫ് നഴ്സുമാരെ എല്ലാം ട്രെയിൻ ചെയ്യുക. ആ ഗൈഡ് ലൈൻസും എല്ലാം ഫോളോ ചെയ്യുക എല്ലാ സിറ്റുവേഷനിലും.
This is the ideal time, because 2025 we have update after 5 years, so you can very well have classes. ഞാൻ പറയുന്ന CPCR മാത്രമല്ല, എവറി സിനാറിയോ യു ഷുഡ് ഹാവ് ട്രെയിനിങ്. കാരണം ഈ ഔട്ട് ഓഫ് ദ ബോക്സ് വരുന്ന പേഷ്യൻസ് കേസസ് വളരെ കുറവായിരിക്കും. ഇപ്പം ട്രോമ വരുമായിരിക്കും, DK വരുമായിരിക്കും, MI വരുമായിരിക്കും. കുറെ ഫിക്സ്ഡ് കേസസ് ആണല്ലോ വരുന്നത്. അല്ലെങ്കിൽ 10 അല്ലെങ്കിൽ 15, അതിൽ കൂടുതലൊരു താലൂക്ക് ഹോസ്പിറ്റലിൽ വരാൻ കുറവാണ്. അപ്പം അതിനുള്ള ബേസിക് കാര്യങ്ങൾ ചെയ്യാം. AHA സൈറ്റിലുണ്ട്, 2025 ഗൈഡ് ലൈൻ AHA സൈറ്റിലുണ്ട്. അത് പല പാർട്ടാണ് കൊടുത്തത്. ഓരോ പാർട്ടും PDF ഒരുമിച്ചില്ല. എവറിത്തിങ് ഷുഡ് ബി ഡൗൺലോഡ് സെപ്പറേറ്റ്ലി. Basically, I think there are 13 or 14 parts.
ഒരു ക്വസ്റ്റ്യൻ, ഹൗ ക്യാൻ സർ, 2 ക്വസ്റ്റ്യൻ ഉണ്ട്. ഹൗ ക്യാൻ വി ഇംപ്രൂവ് ചാൻസ് ഓഫ് സർവൈവൽ ഇൻ VF എന്നുണ്ട്.
ഒരു കാര്യം ഞാൻ പറഞ്ഞല്ലോ, CF സംതിങ് കോൾഡ് ആസ് എ സഡൻ കാർഡിയക് ഡെത്ത്. സഡൻ കാർഡിയക് ഡെത്ത് എന്തുവാണ്? The patient coming to the best and he collapses, he dies. Patient കഴിച്ചുകൊണ്ടിരിക്കുന്നു, he falls down, he dies. അപ്പം VF is the most common arrhythmia, അല്ലെങ്കിൽ the rhythm pattern that you find in patients who have sudden cardiac death. VF ആണ്. ഓക്കെ, VFന്റെ ട്രീറ്റ്മെന്റ് ഞാൻ പറഞ്ഞു defibrillation ആണ്. ബട്ട് ദെൻ meanwhile, till you get the defibrillator, you have to do high quality CPCR. So the answer would be high quality CPCR and immediate defibrillation. Every minute you lose, there is mortality increase by 7% VF. അതുകൊണ്ട് in Western countries, when you call 911, the ambulance would come in 5 to 7 minutes. അതാണ് അവർ പറയുന്നത്. Anywhere, they will come in 5 to 7 minutes. And that is not feasible in our scenario. ചിലപ്പോൾ ഇവിടെ അരമണിക്കൂർ എടുക്കും. So it might be easier for you to transfer the patient to the hospital or to the defibrillator. Hospitals, not all wards have a defibrillator. So who brings the defibrillator? You have to take the patient to the ICU where you have the defibrillator. അതേ ഒക്കൂ. സോ ആ കൾച്ചറൊക്കെ മാറി വരണം. സോ ഇഫ് യു ഹാവ് ഏരിയാസ് ഇപ്പം ലേബർ റൂമിൽ there are chances the patient can have a cardiac arrest. So ആ റൂമിൽ there should be a defibrillator. You should have a ECG monitor and all the emergency drugs. Where can we get hands-on training? I would recommend we have the AHA giving the full training. ഇവിടെ പല സ്ഥലങ്ങളുണ്ട്. It might cost something around 10,000 rupees, but then it's worth taking that training. അവർ പെർഫെക്റ്റ് ആയിട്ടാണ് ചെയ്യുന്നത്. വി ഹാവ് ഒരു ഏജൻസീസ് ആണ് ചെയ്യുന്നത്. അത് പരസ്യമായിട്ട് വരും സാധാരണ. അത് ഓരോ ടിപ്പിക്കൽ സമയത്താണ് വരുന്നത്. അത് ഒരു ടൈം പീരീഡിലേ വരും, എല്ലാ ദിവസവും ഒന്നും കാണൂല. പിന്നെ അറ്റ്ലെക്കിലുണ്ട് where you can get the training. അറ്റ്ലെക്കിൽ we have the training. I think many of you have attended that, no? The training at Atlek.
ഉണ്ട് സാർ, തിരുവനന്തപുരത്ത് ഉണ്ട്. സാർ അപ്പെക്സ് ട്രെയിനിങ് സെന്റർ അല്ലേ ഉദ്ദേശിച്ചത്?
അതെ.
ഡോക്ടർ ശ്രീകാന്ത് ആണ് അതിന്റെ.
You can get training at medical colleges also. Casualty, you can get training. So it would be like you would have more number of patients there. Casualty training ചെയ്യാം. നമുക്ക് എല്ലാം അറിയണമെന്നൊന്നുമില്ല. എല്ലാം നമ്മൾ റീലേൺ ചെയ്യണം, മറന്നുപോകും. ആൻഡ് ഹാവ് ദ ആറ്റിറ്റ്യൂഡ് ടു സ്റ്റഡി അഗെയിൻ ഡിഫറെന്റ് തിങ്സ്. ന്യൂ തിങ്സ് ആർ കമ്മിങ് അപ്പ്. You can, if you are like you want to refresh, you can come back and then get a 1 week training at casualty. And intubation is not always a must. I should emphasize. I think it might have been emphasized during the BLS class. BLS, it's not mandatory that always the first thing you intubate. So the intubation is like I told you, don't waste time. Don't stop your CPCR for prolonged periods for the need of intubation, like for intubation. Our concept should be very clear. So intubation is not a priority in CPCR if you can very well ventilate the patient. So the basic skill you all should learn is to use the ambu bag to ventilate the patient. Dr. Rakesh has said that it's a high voltage tense scenario. So what kind of patient did you try to intubate or give CPCR? Is it because a lot of people looking at you or like they don't have trust in you? What was the real problem? Rakesh Kumar has said that training sessions we do on dummies, so it is very different in real life. Don't have isolated places where you have to do the restation. നമ്മൾ അതൊക്കെ ബിൽഡപ്പ് ചെയ്യണം. എല്ലാവരുടെയും ഫ്രണ്ടിൽ വെച്ചല്ലേ നമ്മൾ ഇൻഡിബേറ്റ് ചെയ്യേണ്ടത്. എസ്പെഷ്യലി ഇൻ ദ കാഷ്വാലിറ്റി യു ഹാവ് റീസ്റ്റേഷൻ ഏരിയാസ് വെയർ you have all the things ready, all the gadgets ready. We can use the video laryngoscope. Newer gadgets ഒക്കെ വന്നിട്ടുണ്ട്. വീഡിയോ ലാരിഞ്ചസ് നമുക്ക് കണ്ടുകൊണ്ട് ചെയ്യാം. You can use the സ്റ്റില്ലറ്റ് ഉപയോഗിക്കാം, ബൂജി ഉപയോഗിക്കാം, അല്ലേ? ബൂജിയൊക്കെ വരാൻ ഇറ്റ്സ് സോ ഈസി. You can see and then direct that and then railroad the tube into that. And again, I really emphasize that the skill you should learn is ventilation, mask ventilation rather than intubation is also one thing you should learn. But then, if you can mask ventilate a patient, you can save the life. Again, what you said might be like maybe those patients might not be having proper sedation and muscle relaxants when you try to intubate. That is another very common scenario that I see. Sedation illada you try to intubate. Maybe not in cardiac arrest, but then a patient who is going sick, when you want to intubate, you should give sedation. And muscle relaxants is a bit a problem because you are afraid that patient will go to apnea and patient will not take breath and patient will crash then. That is a problem only when you feel that you cannot do back mask ventilation. Back mask ventilation കയ്യിലുണ്ടെങ്കിൽ you give apnea വന്നാൽ നമുക്ക് വെന്റിലേറ്റ് ചെയ്യാൻ നോക്കും.
സാർ നമുക്ക്
ഒരു question.
wind up ചെയ്താലോ?
It is important to give guidance in railway for using. Yeah, I told you that Vande Bharat AED ഉണ്ട്, and majority of our railway stations Tambanur undennaanu ende vivalamaaya vishwasam. How can you give oxygen during? Yes, you can. You can give. You can attach the oxygen at the end of the ambu bag. Ambu bag in the at the matte end, mask load connect the other end would have a port for the oxygen, and you also have a reserve bag. At the end of the ambu bag, on the other side, you would have a plastic bag which is quite big, and that will act as a reserve for oxygen. So by giving connecting that and keeping a flow of around 10 to 15 liters, you can give up to 100% oxygen with the ambu bag. So that is the advantage. It does not need any current. Compressed gas venda, only oxygen that is needed. It is a self-inflating bag. That is the advantage of using ambu bag. So all these basic life-saving skills should be learned. And I think you have ATLEC providing classes. ATLEC nalla class undu. I think it's a 3-day affair, 3 or 2-day affair where you'll be trained in most of the emergencies. You would have hands-on and dummies. And if you really want to have the Pakka training, you can contact the AHA. AHAക്കാർ ഇവിടെ ട്രെയിനിങ് കൊടുക്കുന്നുണ്ട്. ACLS AHA ട്രെയിനേഴ്സ് ഇവിടെ കൊടുക്കുന്നുണ്ട്. കിംസി ഇടയ്ക്ക് വന്നായിരുന്നു, കോട്ടയത്ത് വരും, പല പല സ്ഥലങ്ങളിലായിട്ട്. എറണാകുളത്തുണ്ട്. There are just search in the net whether you get the ACLS training. And that certificate holds good for 1 to 2 years. ഒരു ബാഡ്ജ്, ഒരു ID കാർഡ് പോലെ ഒരു സാധനം തരും, that you are trained. ശരി സാർ, അപ്പം വേറെ അല്ലെങ്കിൽ
ഓക്കെ സാർ, നമുക്ക് വൈൻഡപ്പ് ചെയ്യാം. സാറിന്ന് പറഞ്ഞ പോലെ മോസ്റ്റ് ഇമ്പോർട്ടന്റ് പോയിന്റ് അൺഇൻട്രപ്റ്റഡ് ഹൈ ക്വാളിറ്റി CPR ആണ്, വിത്തൗട്ട് എനി ഡിലേ. അതാണ് നമുക്ക് ഡീഫിബ്രിലേഷൻ ഒക്കെ റെഡിയായി വരാനായിട്ടൊരു സമയമുണ്ട്. നമുക്ക് ഹോസ്പിറ്റൽസിൽ ഒരു ചെറിയ ലാഗ് ടൈം ഉണ്ട്. പക്ഷെ അപ്പം നമ്മൾ ഹൈ ക്വാളിറ്റി അൺഇൻട്രപ്റ്റഡ് CPR, ഒന്നിനു വേണ്ടിയാണെങ്കിലും ഈ CPR ഇന്ററപ്റ്റ് ചെയ്യരുത്. ഇന്ററപ്റ്റ് ചെയ്യുന്നതോറും നിങ്ങളുടെ ഔട്ട്കം മോശമായിരിക്കും. ഞാൻ ഇപ്പൊ വടക്കാഞ്ചേരി ജില്ലാ ആശുപത്രിയിലാണ് വർക്ക് ചെയ്യുന്നത്. ഞങ്ങൾക്ക് സെപ്റ്റംബറിൽ ഞങ്ങൾക്ക് 2 CPR ഉണ്ടായിരുന്നു. ഒന്ന് ഷോക്ക് അടിച്ചു വന്ന ഒരു പേഷ്യന്റ് ആയിരുന്നു, KSCBയുടെ കോൺട്രാക്ട് വർക്കർ ആയിരുന്നു. അദ്ദേഹത്തെ ഞങ്ങള് 3rd ഷോക്കിന്റെ കൂടെ അമിയോട്രോൺ കൊടുത്തു, അദ്ദേഹത്തെ റിവൈവ് ചെയ്തു. അദ്ദേഹത്തിന്റെ ഔട്ട്കം വളരെ നല്ലതായിരുന്നു, ഫുള്ളി റിക്കവർ ചെയ്തു, സെൻസോറി എല്ലാം നന്നായി റിക്കവർ ചെയ്തു. 36 years ഉള്ളായിരുന്നു. രണ്ടാമത്തെ കേസ് വേറൊരു ഡോക്ടറായിരുന്നു, ഹാങ്ങിങ് ആയിട്ടാണ് വന്നത്. ഹാങ്ങിങ് ആയിട്ട് വന്ന് അറസ്റ്റ് അടിച്ചു, അദ്ദേഹത്തെ റിവൈവ് ചെയ്തു. അദ്ദേഹത്തിനും 22 വയസ്സേ ഉള്ളായിരുന്നു, അദ്ദേഹവും നല്ല ഔട്ട്കം ആയിരുന്നു. അതുകൊണ്ട് നമ്മൾ ശ്രമിച്ചാൽ തീർച്ചയായിട്ടും നമ്മുടെ ഗവൺമെന്റ് ഹോസ്പിറ്റലുകളിൽ തീർച്ചയായിട്ടും ചെയ്യാൻ പറ്റും. അപ്പൊ നമ്മളാ BLS ക്ലാസ് എല്ലാവരും വാച്ച് ചെയ്യുക, നമ്മൾ ട്രെയിൻഡ് ആവുക, സ്റ്റാഫിനെ ട്രെയിൻ ചെയ്യുക, വീണ്ടും ട്രെയിൻ ചെയ്യുക. നമ്മുടെ ഹോസ്പിറ്റലിലൊരു പ്രോട്ടോകോൾ പോലെ ആയി കഴിഞ്ഞു കഴിഞ്ഞാൽ തീർച്ചയായിട്ടും നമുക്കത് ചെയ്യാൻ സാധിക്കും. ഏതായാലും മറ്റേ എന്തിനു വേണ്ടിയാണേലും ഹൈ ക്വാളിറ്റി CPR ഇന്ററപ്റ്റ് ചെയ്യരുത്, എന്നാലേ നമ്മുടെ ഔട്ട്കം നന്നായിട്ട് വരുള്ളൂ. അപ്പൊ ബാക്കി സാറ് പറഞ്ഞ പോയിന്റ്സ്, നമ്മുടെ BLSലെ ക്ലാസ്സിലെ പോയിന്റ്സ് എല്ലാം നമ്മൾ തീർച്ചയായിട്ടും പ്രാക്ടിക്കലി അപ്ലൈ ചെയ്യേണ്ടതാണ്. അപ്ലൈ ചെയ്ത് കഴിഞ്ഞാൽ തീർച്ചയായിട്ടും ഔട്ട്കം നല്ലതാണ്. പിന്നെ സാറ് പറഞ്ഞ പോലെ ഹൈസ്കൂൾ പിള്ളേരെയും +2കാരെയും അങ്ങനെ നമ്മുടെ കരിക്കുലത്തിന്റെ ഭാഗമായിട്ട് തന്നെ ഒരു CPRന്റെ ഒരു കൾച്ചർ ഉണ്ടാക്കി എടുക്കുകയാണെങ്കിൽ തീർച്ചയായിട്ടും ഔട്ട്കം കുറച്ചുകൂടെ നല്ലതാണ്. ഗവൺമെന്റ് അവയർനെസ് കൂട്ടാനായിട്ട് ശ്രമിക്കുന്നുണ്ട്, കരിക്കുലത്തിൽ കൊണ്ടുവരുമെന്ന് നമുക്ക് പ്രതീക്ഷിക്കാം. പക്ഷേ ഏതായാലും CPCR, അഡ്വാൻസ്ഡ് CPCR നമ്മൾ ഡോക്ടേഴ്സിന് മാത്രമേ പറ്റുകയുള്ളൂ. അപ്പൊ അത് ഡോക്ടേഴ്സിനും നമ്മുടെ ഹോസ്പിറ്റൽ സെറ്റിങ്ങിലും. അപ്പൊ അത് തീർച്ചയായിട്ടും നമ്മളത് ഈ ക്ലാസ്സിൽ നിന്ന് പഠിച്ച പാഠങ്ങൾ ഉൾക്കൊണ്ടുകൊണ്ട് നമ്മൾ സ്വയം ഒന്നുകൂടെ പഠിച്ച് ഇംപ്രൂവ് ചെയ്ത് അത് അപ്ലൈ ചെയ്യുകയാണെങ്കിൽ തീർച്ചയായിട്ടും നല്ല ഔട്ട്കം കിട്ടും. നമ്മൾ ഹാഫ് ഹാർട്ടഡ് ആയിട്ട് അറ്റംപ്റ്റ് ചെയ്യാതെ സിൻസിയർ ആയിട്ട് അറ്റംപ്റ്റ് ചെയ്യുക, നമ്മുടെ കൂടെയുള്ള സ്റ്റാഫിനെയും ട്രെയിൻ ചെയ്യുകയും ചെയ്താൽ തീർച്ചയായിട്ടും നല്ല ഔട്ട്കം വരുന്നതായിരിക്കും. KGMOയുടെ പേരില്
usually I start with saying that CPCR giving doing a successful CPCR സാറ് പറഞ്ഞ പോലെ വളരെ നോബിൾ തിങ് ആണ്, ഒരു വലിയ പുണ്യകാര്യമാണ്. കാരണം യു ആർ ഗിവിങ് ഒരു റീബർത്ത് ആണ്. ശരി, ഇഫ് യു ഡു ഇറ്റ് റൈറ്റ്ലി ആൻഡ് ഇഫ് യു ദ സർവൈവൽ ഫോർ വാട്ട് യു സെഡ്, ബോത്ത് ദ പേഷ്യൻസ് സർവൈവ്ഡ് വെരി വെൽ. അവരുടെ ജീവിതം തിരിച്ചു കിട്ടുമെന്ന് പറഞ്ഞാൽ വലിയൊരു ഭാഗ്യം തന്നെയാണ്.
തീർച്ചയായിട്ടും അത് സാറ്റിസ്ഫാക്ടറി ആണ്. ഞങ്ങളെ സേവ് ചെയ്ത ദൈവത്തിന്റെ കാരുണ്യം. 36 year old അദ്ദേഹത്തിന് 2 വയസ്സും 4 വയസ്സുള്ള കുട്ടികളായിരുന്നു. അല്ല, അദ്ദേഹത്തിന് ആ ഒരു ദിവസത്തെ ഓർമ്മ മാത്രമേ ഇല്ലാത്തുള്ളൂ, ബാക്കി ഹി റിക്കവേർഡ് ഫുള്ളി. ജോലിക്കും പോകുന്നുണ്ട് ഇപ്പൊ. ഞാൻ ഏതായാലും തിരക്കിട്ട സമയത്തിനിടയ്ക്കും നമുക്ക് വേണ്ടിയിട്ട് ഈ ക്ലാസ് വേണ്ടി സമയം ചെലവഴിക്കുകയും ഇത്രയധികം സമയം സാറ് ഞങ്ങളോട് ചെലവഴിക്കുകയും ചെയ്തു. സാറിന് KGMOയുടെ പേരിലും അക്കാഡമിക് സെല്ലിന്റെ പേരിലും എന്റെ പേഴ്സണൽ ഇതിലും ഞാൻ സാറിന് ഞങ്ങളുടെ ഹൃദയത്തിൽ നിന്നുള്ള നന്ദി അറിയിച്ചുകൊള്ളുന്നു. തീർച്ചയായിട്ടും സാറ് വളരെ നന്നായിട്ടാണ് എല്ലാ കാര്യങ്ങളും പറഞ്ഞ് അപ്ഡേറ്റുകളെല്ലാം നന്നായിട്ട് പറഞ്ഞു. സാറ് തീർച്ചയായിട്ടും നമ്മുടെ പാർട്ടിസിപ്പൻസിനെ മോട്ടിവേറ്റ് ചെയ്തിട്ടുണ്ട്. സാറിന് ഏതായാലും ഞാൻ ഒരിക്കൽ കൂടി നന്ദി പറഞ്ഞുകൊള്ളുന്നു. താങ്ക് യു വെരി മച്ച് സാർ.
താങ്ക് യു.
താങ്ക് യു സാർ.
ശരി,
നമുക്ക് വൈൻഡപ്പ് ചെയ്യാം സാർ.
ഓക്കെ, ലീവ്.
താങ്ക് യു.